I have no conflict to declare, I thought. But actually, I think I have a conflict because I don't have any sophisticated assay to discuss with you. I don't have any fashionable result. I understand that to enjoy the invitation to be here with you in St. Gallen, I have to accept to play the role of the traditional, old-fashioned pathologist. So I'll do that. And so we will discuss about pure morphology and to try and address the question of what is the role of the pathologist in the post-neoadjuvant chemotherapy setting. Actually, I think it's quite easy. We have two main tasks. Number one is to ensure accurate assessment of PCR. And second, to evaluate the residual tumor burden and the biological characteristics in case PCR has not been achieved. So, it should be quite easy. But then, especially after the yesterday afternoon session where we were discussing about tumor markers and clinical validity and analytical validity, I start thinking that PCR is a primary endpoint in the neoadjuvant trials. Actually, PCR is considered a prognostic marker. So, if it is a prognostic marker, have we ever thought about its analytical validity, clinical validity, or just our only concern is Ki67? So if Dan is around, I would like to ask him whether it's not time for us to look at PCR, also at PCR, as something that has to be tested against analytical validity, and clinical utility. Actually, let me start with what is PCR? We have several different definitions of PCR. Absence of invasive cancer in breast and breast axilla, or absence of invasive and in situ cancer in breast only or in breast in the axilla. Do we care of residual isolated tumor cells in the breast and in the nodes? Do you want us to try and find them, or should we ignore them? So these are kind of questions that, in terms of analytical and clinical validity, should raise some issues. I know that there is a proposal from FDA. This is the last version that I know of the proposal. Maybe there is a new one yesterday, but the proposal was pathologic complete response is defined as the absence of any residual invasive cancer, but on H&D evaluation of the resected breast specimen and all sampled ipsilateral lymph node following completion of neoadjuvant chemotherapy. And again, there is the myth of pathologists that they are not able to pick up individual tumor cells without the aid of cytokeratin immunostaining. So the problem is, if your pathologist is able to pick up one individual cell on H&D, that will be a residual tumor. But if he wants to have a immunohistochemical staining to pick it up, he's not allowed to do that, or in any case, it's not a residual tumor. So residual tumor may depend on the assay that you are using, whether it is H&D or immunohistochemistry, well, which is not an easy issue to address. As all those markers, also for PCR, I think there are some pre-analytical variables. Indeed, your pathologist, prior to examination of the surgical sample, has to know whether the patient has received neoadjuvant chemotherapy or not. I don't know in other countries, in other centers, but in my country, sometimes in my center, it may be quite difficult to find in the clinical history the information that she has received neoadjuvant chemotherapy. And then we have to learn how to figure out that maybe she has received neoadjuvant chemotherapy, for instance, taking into account a long time interval between the previous core biopsy and surgery. Or if you start asking the question to yourself, why did they take this breast? I don't see anything, but there must be a reason why they have taken them out. So you see, these are pre-analytical variables that may affect the reliability of PCR assessment by your pathologist. Then we have to try and call the clinician or to look into the clinical charts of the patients to see whether, as we think, she may have received neoadjuvant chemotherapy. And then we have to check the radiology report for tumor locations. Sometimes there were multiple foci, and any information about radiological response. And then there is the analytical portion of the job, which is gross examination of the specimen after neoadjuvant chemotherapy. And the task there is identify the tumor bed. It is imperative for us to identify the tumor bed, even though this may be challenging, especially when there is a substantial clinical response. The tumor bed, the problem is that tumor beds, they do not read the books, and so sometimes they do not know that they have to appear as an irregular area of rubbery fibrous tissue with or without any residual tumor, which may be visible. So this is what we are facing. This is, you see, the whitish, rubbery, fibrous tissue. This is the original tumor bed. There is no obvious residual tumor here, but in this different image, there is some residual tumor. So we have to look for this original tumor bed and any residual tumor, and then start measuring. We have to measure the specimen size, the original tumor bed size. If there are tumor nodules, we have to measure the tumor nodule size, and then the distance of the tumor bed from all the margins. And this is an example where the tumor bed goes touching the ink at the margin of the surgical resection. And you see here the tumor bed, the way we are measuring, and the margin. Additional analytical variables. How many blocks should we take from the surgical specimen? And here it's quite funny because there is such a huge variability, both in the study protocols, trials for neoadjuvant, whatever. And if you look into the protocols, the SOPs of these trials, each individual trials most likely has a different way of looking for a residual tumor. So the rules are different. Sometimes you have to submit all the specimen for histology, irrespective of the size. Some tell us just submit all the tumor bed. Someone say, oh, listen, just take 1 block per centimeter, which is enough. Or, listen, just submit whatever you want. So I think that harmonization is needed. And actually, the Breast International Group and the North American Breast Cancer Group have elected a number of people involved in the neoadjuvant trials within a working group which would try and address the main issues of the residual disease characteristics characterization in the post-neoadjuvant setting. And hopefully, this group will eventually end up with some sensible recommendations about how to deal with these analytical variables. And then after having sampled the surgical specimen, we have to go to the microscope and look for any residual tumor. Cellularity, size, margins, grade. I put a question mark here because, again, we are thinking of grade as an important prognostic parameter, but this is based on what we know of the grade in cases without neoadjuvant chemotherapy. So we know that we have to look at the architecture of the tumor, tubule formation. We have to look at the size and shape and quality of the nuclei and the mitotic index. So this is the histological grade. But when we transferred everything to the post-neoadjuvant setting, then I have a question. Is tubule formation after neoadjuvant chemotherapy, is the shape and the characteristic of the nuclei in these cells, is the mitotic index a true mirror of the biological characteristics of the tumor? Or these are just effects of the neoadjuvant chemotherapy over the cell? Is the shape of the cell dictated by intrinsic biology or by the chemotherapy? So is the same prognostic, has the same prognostic value pre-neoadjuvant and post-neoadjuvant? I have no idea. And finally, we have to look for the tumor markers. And then we know 20% of the cases maybe overall, much more for progesterone receptor than estrogen receptor, something less for HER2, they are changing. Are these changes, again, biology? Are there technicalities, false positive or false negative assessment in the prior biopsy and in the post-surgical specimens? Are these changes due to the effect of the therapy? Again, we do not know. But we are ready to change we are ready to change the therapeutic approach to these patients, maybe based on the conversion of a marker, without knowing whether this is true conversion or technical artifacts. Let me just show you a difficult case. This is a tumor bed. I see fibrosis, I see some most likely inflammatory cells, some strange cells here. And then at higher magnification, I see Indian files. Cells in Indian file, is it invasive lobular? Is it plasma cells? So I may play with immunohistochemistry and see that these are actually inflammatory cells, but then there is, again, another Indian file of cells here. Are they the same plasma cells as before? Well, I'm quite a self-confident pathologist. I can tell you this is tumor cells, residual tumor cells. So according to the FDA proposal, this will be residual tumor. But if I was less confident with myself, I would have done immunohistochemistry to show that these actually are tumor cells. But in that case, I'm out of the definition of PCR according to the FDA proposal, so I don't know what to do. Most likely, I will stain without telling you that I stained. Italian way. And then we have the post-analytical issues. Post-analytical issues is staging. How can I tell you how much tumor is left whenever there is no pathologic complete response? Because we know that these tumors, again, they are quite difficult to cope with because, well, if there is pathologic complete response, it's easy. There is no tumor there. It is T0, is no tumor left. But then chemotherapy may lead to a shrinkage of the tumor, a kind of concentric shrinkage of the tumor. So I have something to measure. It's defined. I can take just size, and it's easy. But then there is this kind of partial response with small islands of tumor cells all over the tumor bed. How can I tell you what's in here? How can I measure it? How can I stage this residual tumor? Well, we have different systems. I will just try and address 2 or 3 of them. We have the AJCEC, PTNM classification, staging. We know that we have to use the prefix Y in order to tell you, listen, this is post-neoadjuvant therapy, the staging. And then, if I find multiple nests, even tiny nests of residual tumor, but within the entire tumor bed, then I have to measure the extent that encompasses these tumor nests in order to have the YT staging. So, can you imagine a 2.5 centimeter tumor bed with maybe 150 tumor cells here and there? But I have to measure 2.5 centimeter, it will be PT2. So it was PT2 before chemotherapy, it remains YPT2 after chemotherapy, but now I have only 100 tumor cells, residual tumor cells. So most likely this system will overestimate the stage of the tumor post-neoadjuvant. It does not include changes, the PTM system, in tumor cellularity, and then again, we do not know whether the clinical impact of isolated tumor cells in the breast and in the nodes and micrometastasis in the nodes have the same clinical implication as in patients without neoadjuvant chemotherapy. We know that we can disregard this in the non-neoadjuvant setting. Sometimes we can disregard this. But how about post-neoadjuvant setting? Is it the same information or it has different prognostic implications? The Miller-Payne system is an alternative to TNM, uses cellularity to divide tumors into 5 stages without starting from no reduction in overall cellularity, no response, to complete response and all the intermediate. These 5 different stages do correlate with long-term outcome, but lymph node status is not included, and especially you will have to have the previous core biopsy in order to be able to compare the cellularity prior to neoadjuvant chemotherapy with the cellularity after neoadjuvant chemotherapy. And lastly, we have the residual cancer burden system, where several parameters, primary tumor bed area, residual cancer cellularity, percent DCIS, number of positive nodes, size of the largest metastases in the positive nodes, may allow to calculate, to subdivide the residual tumor in 4 classes from 0, which equals to PCR, to 3, which is chemoresistance. And again, there is a web-accessible formula to help us in this venture. And again, there is some prognostic implications because you see that when there is pathological complete response or minimal residual tumor, the clinical outcome of the disease is quite good, whereas with increasing residual tumor, then there is a worse outcome. So maybe sizing tumor may be important from a clinical point of view, but my question again, especially in case of minimal residual tumor, my question is that this minimal residual tumor has no clinical impact because it is an issue of number of tumor cells, size of the tumor, or again, biological properties of this tumor. You know, when I see 10, 20, 50 tumor cells, I can see them. I can identify them as tumor cells. But you know what? I do not know whether they are living tumor cells or if they are dying tumor cells. I do not know whether they will be able to induce tumor progression or not. I do not know whether they are tumorigenic or not. So looking at the biology of the residual tumor may be even more important than looking at the numbers or the size of the tumor. So my last slide is that neoadjuvant chemotherapy for sure will be used more frequently, both in clinical research and in daily practice. Assessing tumor response will always be a critical responsibility for the pathologist, but we desperately need harmonization of protocols for macro and microscopic evaluation of tumor response and for learn how to assess the prognostic predictive value of the morphological and biological markers of this residual tumor. Thank you very much for your nice attention.